So we welcome our panel. We have a live case coming from Asan of a left atrial appendage occlusion, and we're checking now on the lab status.
Well, we're almost finished.
There we are. Okay. Good evening, gentlemen. Can you hear me?
Yeah, we can hear you very well.
Beautiful. We can hear you as well. Saibal, welcome. We're ready to see your magic. Maybe you could introduce your staff there and then the case.
So I'm just a guest over here. It's not. So I'm actually having a great time over here. We're having kimchi and a lot of food. On my left side is Dr. Jun Kim, who's an electrophysiologist. On the right side is Duk-Woo Park. He's an interventional cardiologist. And Dr. Joe, he's another electrophysiologist. I'm kind of sandwiched between two electrophysiologists. We have many of the staff. Mandy, I know from many days. We have Minjang from Boston Scientific. We have Dr. Kim, who's actually doing the echocardiography. And I think before we start, do you want to describe the case?
Yes. 70-80-year-old woman with paroxysmal AF was admitted for LAA appendage occlusion. She, as shown in here, she had many medical conditions, including chronic kidney disease and multiple GI bleeding during the oral warfarin therapy. Next slide, please. And next. Based on high CHD score and high head blast score, we think the LA appendage occlusion was the best treatment option in this patient.
So, do you have the case? Yes. Are there any questions?
Just one quick question. Given that she has some difficulty on even low-dose Coumadin therapy, will you maintain her on the 45 days of warfarin after the Watchman implantation?
We discussed this. What do you think? I mean, I was preferring you to do Coumadin for 45 days, but you want to give Plavix. Is that correct?
Yes. It is a recommended therapy during 6 weeks oral anticoagulant therapy, but the patient and his family member does not want long-term anticoagulation therapy because very rare INR. One time was INR was 4.0 and the next time was 10.0. Very high risk patient.
Yes. Okay.
So, but in the US, I would try to give Coumadin. So I just want to show I think we all agree this is a great candidate for this device. Do you agree with that in the panel members?
Yes.
Yes. Dr. Kim, do you want to show the pictures? We just taken some echo pictures and we want to show you the images.
I'm going to show you some images. This is a 0-degree view. The ostial diameter was 23. This is the largest diameter.
So that's
in this
the maximum
patient.
diameter that we got.
And then the 45, with the diameter was 21. And 90-degree view, the diameter was 19. And 135-degree view, the diameter was 19. This is the final septal puncture size in this patient.
So you saw that we saw the sizing. I think, based on the sizing, I think the best, I thought I'll do something like 420 as 27 device. Is that okay with you guys?
It sounds fine.
So we did the transeptal while we were waiting because you went over time. You can see that the puncture is posterior and low. This is a critical part of the procedure. And then once we entered into the septum, across the left atrium, we measured the pressures. It was actually low. So we gave some fluids, which is important. And then we remeasured again. It's almost the same measurements. And now we advanced over a super stiff wire, we've advanced a 14 French sheath. I usually use the single curve, not the double curve sheath inside. So let's go live now.
So talk to us about your choice of transeptal puncture location.
So the most important part of the procedure is the transeptal puncture. And you have to be posterior and low because you really want to go along the long axis of the appendage. So that's why I always use posterior and low. And most of the time that's accepted. You can see in the bicommercial. Okay. So now we've got the sheath in. And as you can see, the flora is live. You have the super stiff wire there. And you can look down these things. I'm just taking out the dilator. And we're just going to aspirate and flush this there. Close this here. And interesting way is you shouldn't aspirate too gently. Just allow it a gentle drip. Let blood come back and then flush the sheath and then you're all set. So the next step is to use a pigtail catheter, if I have the pigtail. And now the sheath is in the pulmonary vein. So just to show 45 and 135, so that echo. And we'll use the pigtail catheter, and we're going to use, with the help of the pigtail, we're going to advance it into the left atrium. Now, so other people put the wire in the left atrial appendage. I think Horst is there, right? Is Horst sharing the session with you?
Yes.
Yes, that's a preferred technique, Saibal, but go ahead with your technique. It's fine.
Well, okay, Horst. I just like to do anything that Horst does. I just want to do the opposite. Horst, what size would you use? You'd use 33, right?
Say again. Double?
The Horst is always 5 millimeters larger than everybody else. Yeah. So, Horst, based on the sizing, what do you think, Horst?
I missed the sizing because I was late. So what is the maximum diameter
Oh,
you
okay.
measured?
The maximum diameter is 22 in a 0 degree. The rest is 20.
27 or maybe 30. Huh? What size
Oh,
do you
come
have?
on, Horst. Why not 33?
No, too small.
Okay. And by the way, we have anesthesia for this patient, since you don't have that in Germany.
Oh, we don't have that. We don't need it. Germans are allergic against general anesthesia.
That's right. So we're just flushing and getting the picture
Saibal,
ready.
it's YY from Hong Kong. Hello.
Hey, YY, how are you doing? YY, you
Great.
don't even believe in echo.
So in this patient, it looks like the LA depth is quite shallow. So is that a reason that
Yes.
you don't want to choose an oversized, let's say 30 device, or 31 device?
Oh, no, I would never use a 30. I'm going to use 27, or I was thinking of 27 or 24.
But I think the point is a good one, that the depth of the device, the depth of the LAA
Sure.
does not really support a very large oversizing.
Yeah.
A very important
Yeah,
point.
that's a very good point that he mentioned, that while taking into consideration the device, it is important to also take into the depth. And you can actually use angiography to understand that better. So you can see what I did. I counterclockwise the catheter, and now I'm in the appendage. And let's do arteriocaudal. Arteriocaudal.
30.
김대희 쌤, 그거 조심하세요.
Is it a 5 French pigtail?
Oh no, it's just I think this is a 6 French actually. But I agree with you. 5 French is probably a better choice. You just use. Can you increase the mag by 1? Yeah, that's better. Okay, so I'm advancing the sheath over the pigtail. This is critical, that we are advancing the sheath over the pigtail, and you can see by echo we are in the anterior aspect of the lobe. And I'm just going to give a little test, and then I'll do an angiogram. Okay? Sydney? Yeah.
So this is hand injection?
So you can see. Yeah, this is hand injection. We don't have an automated system like you in Germany. So you can see that the sheath, you can see the landing zone. As you know, YY just mentioned very nicely that there's going to be an issue about the depth. So the sheath has to go a little bit more in order to accommodate a 27, because the second marker is for a 27, right?
Yes.
So what we're going to do is we're going to advance the sheath a little bit more inside. Let's see if it goes in a little bit more.
The
And
diameter
that's
looks
actually
pretty
quite
small here. It looks actually smaller than 20, right?
good. You think so?
Yeah, the diameter of the pigtail is probably 10 millimeters, so pretty small. This is
Right.
arteriocaudal.
Yeah, this is arteriocaudal, which is usually the larger size, as you said. So, I mean, it's going to be a judgment between 24 and 27. I think I'll be able to fit. Just hold this and just take one more picture, and we think we're okay. Just hold this. Yeah. Just hold it.
Saibal, this is Dr. Hara from Tokyo.
Yes.
Oh, could you tell us?
Hi, Dr. Hara, how are you?
Yeah, good. And could you tell us LA pressure now?
The LA pressure, I don't know it now, but the last time when we did it, that's a good point. When we started, it was only 5. And then we gave some volume, it went up to 8. So that's all it is. It's not very high. So that's another reason why we should use a larger size device. Hara, that's a good point, Cindy. Yeah, I think a 27 will be a little tricky, but I'm going to do it. I'm going to do it. Okay, let's get a 27 device.
Saibal.
Yes. Who's that?
Hello. Let me ask a question.
Oh, Dr. Park, how are you?
Very good.
I thought you were supposed to be on sabbatical.
Right. I'm here to see you, your procedure. Could you please let us know why you choose the single curve delivery sheath? And the second question is, this patient has chronic kidney disease. In those patients, how do you reduce the contrast volume? Do you have any tip?
So if you notice, I only gave 2 injections, and that's it. I'm not going to give more. I've already given 5 cc in the first and 5 cc in the second. So we won't give too much of annular. I agree with you. So we're not going to give too much of. That's a good point. I tend to use the single curve sheath for all cases. So I think it's very important that if you do the transeptal puncture correct, and if it's low and it's quite posterior, you're okay with, let's bring it outside. Let's bring it here.
Yeah, I think that's a very good point. I think the double curve is for recovery of a misplaced transeptal, in which case you probably should just re-stick.
Yeah. And the other thing, so can you see the device over here? So the device, as you know, comes in already in the sheath, and I'm just getting it ready to be deployed. So you lock it here. Can you hold it? And then flush this. So we're just flushing it a couple of times. Okay. And then close it and flush it again. Good. So we're going to flush it 2-3 times, and then we'll be ready.
So for the audience, this REO caudal view kind of lays out, or REO, it lays out the atrial appendage and its neck
superior and the posterior.
in the most longitudinal way possible, so you get the kind of greatest expanse without much foreshortening.
Okay, do again. One more. Yes, that's a very good point. That the REO caudal view is equivalent to the 135 view in echo.
Right.
So our working view, therefore, is just REO caudal, and if you want a complementary view, we do REO cranial. But I think the working length, working view is REO caudal. So let me just go ahead, Flora. And I'm just going to put the sheath as much as I can deep inside. Just hold the sheath. A bit of a counterclockwise torque on the sheath. Let me see. That's important.
So that will move it anteriorly.
That's right. Anterior and superior.
And you can see from the echo, it actually should shift a little bit.
Yeah, so it's very nice position now. And then what I'm going to do now is cut.
Saibal, using the straight curve, is there a particular reason?
Yes.
I mean, now you have to rotate counterclockwise to bring it more anteriorly.
No, I know exactly, Horst, what you're saying. You're saying that if you use the double curve sheath, attach it to this flush. Yeah.
We still have to rotate, but maybe less. So why is there a particular reason?
No, Horst, if you notice, if you notice that when you advance the device inside the sheath, the anterior curve goes away.
Yeah.
So it actually doesn't even matter.
Yeah. I agree there's not a big difference, but if there is a difference, then I think the anterior curve can only be beneficial and there's no downside. So that's why I'm asking.
So what I do is, if you do a double curve sheath, if you counterclockwise it, you get 2 motions because it becomes anterior and superior. If you're using a single curve, you get only 1 movement. And that's the reason why I don't like to make it too complicated. I just use 1 movement. Now you see how the sheath is already straightening out when the device is there.
Yeah. It's now against the roof, isn't it?
So I'm just going to pull it back a little bit because I don't want it touching. And this is the time when I give it just 1 more contrast puff just to make sure that I'm not against the wall.
Saibal, remember the device looks perfect. Huh?
Yes, you remember that story, right? And if we had anesthesia, we wouldn't have had that problem. We have a standing joke between both of us. Fluoro? So we're quite deep inside, and so I like to come back a little bit. It's quite deep. And then I'm just going to go a little bit more. You see how the two markers are meeting? Right? And now I'm just going to pull the sheath on.
So important to notice that the device is out of the sheath before the markers are meeting, right?
Right.
Right, yes. And now I'm just going to do a slow deployment.
And that's the business end of the device. That can cause problems if you're not careful.
You want a cine? Cine? Okay. So we did a good deployment. Looks pretty good. It's a little bit of a shoulder, but it's covered it completely. How do you like that?
Looks good.
It's pretty good.
The device looks good.
We knew that it would be a little
Right,
bit
yeah.
long, but it's pretty good.
Yeah. So let's go from the, at this point of time, I'm just going to do a tug test.
Why to start with the tug
And-
test and not look for the other
Well,
criteria?
Horst, the reason why, Horst, I want to do it is that if the tug test it comes out, then we should start all over again. So I don't waste time. So I just want to give a little bit of contrast. Horst, do you want to give some contrast? Cine? Did you see that? That the device moved? That's enough? Good, no more. Good. So now let's look at it. I think it's pretty good. So let's look at the margin now. So he's measuring the device. So let's do one thing. Let's make echo large.
2.43 in 0 degree.
That's good. And let's do color now.
That's
So
good, but
there's
it
no
shouldn't
flow
have
around
been
the
less,
device?
right? So the smaller device would probably have been too small.
Yeah, I think this is the right size, right?
Yeah.
I think if we did 30, it would be even better. I'm just joking.
But maybe, yeah, not enough length, but otherwise, yes.
Shall we change the aliasing
So let's-
velocity for the checking for the leak? Or?
Yeah, already
What's that?
gone.
It's already
Yeah,
30. It's very low.
Yes.
It's pretty low already, yeah.
It's already low. It's 30. Can you measure? There's no color flow around it. There's a bit of a shoulder inferiorly, but I think it's acceptable. Less than 50%. Do you want to put measure it, please? Here. Measure the diameter, please.
Yeah, in this view. Yeah.
There's no color flow anywhere. Yes. And can you want to measure the shoulders, please? Good.
I think at some level, it's part sizing, it's also part coaxial, status. You
Yes.
can't, if you're not perfectly coaxial, you're going to have a little bit of a cant
It's like a
to the
comfort
device,
shoulder.
which I
Yes,
think is
it
what
is.
you've got going on here a little bit. The sizing actually looks quite good.
Yeah. Yeah, and I think it's a little bit of an inferior shoulder, which is less than 50%. I'm not going to recapture and put
Yeah,
it in again.
I agree.
I think it's a good. So it looks quite good, and I just got one more to go, and everything's less than 23, right? So we're going to deploy the device, and I think we're done.
So you've got
You okay with everybody
15 to
that-
20% residual compression. It looks good.
Yeah? And you want to do 0 degree one, system measurement?
Do you want to zero?
Okay,
zero-
that's fine. Do the 45.
Yeah,
That's
yeah,
fine.
yeah, 45.
Yeah, let's do that. You should always measure when you can see the threaded insert. That's important. So that's actually, it's 25. Now, actually, that's a little bit over. Yeah, so let's actually look. That's interesting. It was a little bit larger than I thought. Can we measure that? That's great. No, not that way. When you see the threaded insert, no. Change, no. Yeah, when you see the middle, when you see the center piece, not yet. That's it.
Okay.
Yeah,
Yeah.
freeze. That's correct.
I got it. Yeah.
That's the right way to measure. Okay, good. That's okay. 25 is just compressed. Okay. So you're right, Horst. I mean, it's just compressed and 0 degree.
Saibal, can I see the area cranial view?
Yeah, by what? By fluoro or can? I
Fluoro,
don't want
fluoro.
to give any more contrast. Fluoro? Okay, just do
Yes.
area cranial. Okay, that's a good measurement. Where the okay, looks good. And you see how nice and compressed it looks by
Very nice.
just sitting that for it? No contrast, no. We don't need to give it contrast, okay? So we're done. They just want to do a 3D picture, and I'm just going to deploy the device. So just deploy the device. Just go ahead. So it's full. Let's just talk about it. So you agree with it, the device position's fine. There's no color flow around it. There is a compression, and the tug test was okay. So based on these 3 criteria, we're going to deploy the device. Deploy 8 times. Okay, good. And that's a very nice 3D picture. Let's do one more thing. Good. Let's go. Let's go. And it's out. We don't want to do it, because of contrast, we don't want to do another angiogram. I don't think it's necessary. So I would just pull the sheet back. And that's it. And let's now just focus on the echo. And just one more picture, just have a couple of views. It looks quite good. There's no movement. There's actually no gap at all.
So,
and I think the level looks quite...
Saibal,
yes?
I realized that you pulled the sheath immediately into the right atrium. With your extensive experience in embolized devices, how often does it occur that the device...
Yeah. Actually, first of all, I really like what Horst said. You know, he said it in a casual manner, but I do appreciate what he said. And I think it's a very important lesson to all operators. And I do agree that what I did was probably wrong. I should have kept the sheath in the left atrium while we're doing the final assessments, because if the device embolizes, it will occur now, and to have access is a good thing. So, Horst, I totally appreciate what you said. Actually, the most experience that I've... Yes, Horst?
I think we agree on that point. I just wanted to point out the difference between Watchman and ACP, because in my tremendous experience with embolized devices, when I have an embolization with the ACP, it very often occurred a few minutes afterwards. Whereas with the Watchman, if it embolizes, then it's very soon.
Zero silk.
There's a little difference. But still, I would leave the sheath.
So you think the Watchman did? Yeah. So, you know, Horst, I mean, I'm not trying to boast, but I've done close to 300 Watchmans, and I've never seen an embolization yet. I've had leaks, residual leaks. I've had a thrombus on the device, but I haven't yet seen embolization, and I don't want to see one.
You should pay more attention.
But you're right. But yeah, I should come to your lab more often, maybe.
Saibal, I think the Watchman procedure is already mature procedure. So you are already expert and pioneer for the Watchman deployment. But do you think still you need the general anesthesia? Do you think general anesthesia is mandatory?
Nylon? Yeah. What did you say that? Sorry, I didn't hear you. Do you need anesthesia?
General anesthesia.
Is that your question?
Yeah.
Absolutely. I mean, I think, you know, I know Horst will have a difference of opinion on me on this one, but I really think, at least Horst, you do agree that this is not a trivial procedure. It went smoothly today, but things can go very fast wrong. And, you know, I've had a case where the people have moved and then the sheath has perforated. So I think it's really important that if you do have anesthesia, to use it. I know I have a difference of opinion on this, but I really...
Horst, I know you're not a big fan of anesthesia, but do you use it for these?
I have no experience with general anesthesia with LAA closure, so we never do it. So,
you don't do it?
No, never.
So how do you manage the echocardiographic guidance?
Do you do open heart surgery without anesthesia, or do you do that?
Actually, that's something we should try. The best way with all interventions, when you do it without general anesthesia, is to try to do it without any sedation, because then the patient is more calm. If that doesn't work, then we do sedation with propofol, which is reversible, very short acting. And I don't remember a case where we used general anesthesia for LAA closure, but for other procedures occasionally.
Do you do
the percentage is maybe 1%.
Do you do intermittent TEE? I mean, how do you do it? You constant? I mean,
I try to keep the TE time as short as possible, but we had procedures, just recently we had a different procedure which took 10 hours and without any sedation and anesthesia. The reason is as soon as the probe is in...
Was the patient alive at the end?
Absolutely, and feeling much better than with anesthesia. So when you, the only discomfort is the initial phase when the patient is swallowing, and then when you move the probe. And during these procedures, usually you don't have, you see the T-probe is in the same place all the time.
Yes. All right, so we're going to end this procedure by just doing a figure of 8. Can you show the camera on a figure of 8 suture?
We can see you.
So we take the sheath out. Yep. Can you see the groin? Oh, yeah, that's good.
Yes.
So basically, we take a 0 silk. It's going to be strong. And you do a stitch just below. So I noticed that we have 2 sheets in the groin. We keep, this is very important. We always, if the patient doesn't have previous sternotomy, we always have an extra sheath. So that if you have a tamponade, I use this sheath to infuse the blood back. That's why I always keep an extra venous line in. So, and no arterial line at all. And so now we're going to cover both of them together. So we take one bite just below. And the second one we take above where we think the puncture site would be, which is right here. And this is where it is. And then we do, I want to see how I do the fisherman. This is a fisherman's knot. The fisherman's knot is a self-locking knot. So I will show you that I'll do the whole thing. So you do 3 turns, 1, 2, and 3. And then you would put this.
It's the old ProStar knot.
You put this, that's right, that's correct. So you put this suture here, and then you come out from the side. And then if you pull this, it tightens the knot. If you push this, it slips the knot. And then I'm just going to pull the sheath all in one hand. So one person procedure. You see, it's a self-locking knot. See that? I haven't even tightened it yet. And it's actually quite good. There's no bleeding at all. So
Saibal,
once you push it in. Yes?
How long do you leave?
And then listen, when you... till the next morning.
Next morning. And did you give heparin?
And then you see that once...
Okay, go ahead.
We gave 100 units per kilo.
And do you
and
antagonize
just
at the
one
end?
tightening and that's... Beg your pardon?
Do you give protamine at the end?
I didn't get that. I think sometimes we do. We should have measured the ACT before we ended. Her ACT was quite high. It was actually almost 400, correct?
Yes.
The ACT was quite high. It was 400. But there's no bleeding in the groin. I think it's okay. And so we're done.
Can we see
Any
the
questions?
several views of from the transaspecial echo?
Yeah, sure.
Yeah,
do you want to show some picture of Kim?
So that the one.
We always end with last few. Just make sure there's no pericardial effusion.
Yeah, no pericardial effusion.
Do you want to do a nice 3D for them? Just a good 3D picture?
Very nice case, Saibal. What would be your anticoagulation regime in short term and also in long term in this patient?
So I actually let Jun Kim decide this one because it's his patient. And he was reluctant to give Coumadin, is that correct?
Yes.
And he wants to give aspirin and Plavix, am I correct?
Yes.
Based on the ASAP, he wants to give aspirin and Plavix for 6 months. I would have, in the US, would have given 45 days of low-dose Coumadin and monitored it very carefully. And at 45 days, I would have taken him off Coumadin and just given aspirin and Plavix till 6 months. And at 6 months, take him off Plavix and just be on baby aspirin.
What is low-dose Coumadin?
I believe the levels. The level means I would be a level around 2.
Right.
How about using the new anticoagulant, NOAC?
That I definitely wouldn't use.
So you will not give
On
bridging
any
heparin,
circumstance.
right? Because warfarin usually take few days to work. So no bridging
Yes.
heparin.
See, the thing is that no bridging heparin, and I recommend not to give it because then you land up with a huge hematoma in the groin, blood transfusions, and all bad things. So my recommendation is do not bridge the patient. If you just want to give aspirin and Plavix, it's fine. If you want to give Coumadin, that's fine too, but definitely not. And I've never given Lovenox.
Dr. Carr, I'm Dr. Lim from
Yes.
Korea University. I think the landing zone is slightly proximal, I think, even though the fabric is inside the area appendage. So, but what's the safety margin? I think the landing zone is
Up to
still
50%.
proximal.
Yeah. So I look at this view. This is a good view to see. Can you bring this large, make the screen large? Can you make the echo large? So what he's saying is that in the inferior margin, you can see that the device is protruding up a little bit, okay? And you can also notice that the fabric, 50% of the device is covered with fabric. And so if less than 50% of the device is not protruding out, it's okay.
Pardon? 15 or 20%?
50%. 50% of the device is covered with fabric.
Yes.
And actually, if you look at the echo, can you show the arrow? You can actually see the fabric below the line of the appendage. I mean, I can't point it out, but can you see the brighter spot below the appendage, which means it's below. You understand? That's the fabric. So the fabric is, there's a substantial amount of fabric which is below the ostium. So it's fine. If it was more than this, I would have not accepted this.
Saibal, this is a terrific case, done expertly and quickly because we've got at least 10, 15 minutes left, but we're going to leave you because we've got nothing else to talk about.
Okay.
You did such a good job.
Okay.
Congratulations.
Thank you very much. And on behalf of everybody, thank you.
So, but
Thank you to our panel. Thank you very much, Horst. And we'll see you, I guess, tomorrow. It's the end of today's session.